Bismillah ar-Rahman ar-Rahim. It's a great pleasure to be with you again for the symposium for Sanofi for the DAR conference. The topic of the presentation is the management of hypoglycemia during Ramadan using new basal insulin therapies. Now, we know that the prevalence of fasting during the month of Ramadan among Muslims is quite large. The vast majority of Muslims fast, and as you saw from earlier presentations, that about the DAR Global Survey, indeed, the vast majority of people with type 2 diabetes attempt to fast. To decide on fasting or not, we use a risk calculator. And this you can find in the DAR Academy application, where you will see the DAR IDF risk calculation with various items of the calculation. Part of these items is related to therapy. And indeed, insulin therapy, as you can see here, insulin therapy counts for more than many other types of therapy. Even within the therapy itself, basal insulin have a different level than mixed insulin or basal bolus. So how can we best manage and reduce the risk for the individual on insulin therapy? There are various items we go through the risk calculation and think this already been discussed. The concern, of course, is the hypoglycemia largely, but also we want good glycemic control to prevent hyperglycemia, which, as mentioned earlier in previous presentations, occurs in 50% of people with type 2 diabetes during Ramadan. And of course, severe hyperglycemia and lack of insulin could lead to ketoacidosis. The survey that we did on a large number of people from across the globe, as you can see here, the rates of fasting varies from country to country, but in general, roughly 60 to 70% globally do fast or attempt the fasting. Now, the hypoglycemia rates varies according to the studies that we look. So at the end of the day, the point that we want to do is to maximize the passion for people who want to fast. When we looked into the data from the CREED study, those who attempted to fast over 15% in type 2 diabetes were 94%. Severe hypoglycemia or symptomatic hypoglycemia, which is confirmed in this particular important study, the DAR-MENA study, was quite important because we have looked here into symptomatic confirmed hypoglycemia that increased in Ramadan from 0.11 to 0.22 events per month. And the severe has not really changed much because they were quite rare at 0.01. When we come to the risk quantification, one crucial factor is the medication of the person. And that's something, of course, that we would like to address. What we found in these two studies, in the DAR-MENA trial, as well as in the CREED trial, that the type of therapy is very much important. So in both CREED and in DAR-MENA trial, if the person is on insulin, rates of hypoglycemia is over 3 times those who are on oral therapy without sulfonylurea or any oral therapy, as in the CREED study. 5% here versus 16.8% for insulin only. If they are on oral therapy and insulin, it was 13.5. So that's roughly about 2.5 folds. If we look into in the DAR-MENA trial, those who are on oral hypoglycemic agents and insulin, it was 18%, and those on oral therapy without sulfonylurea, it was 4%. So over 4 folds differences. Furthermore, when we looked into our study that we conducted in Dubai Hospital with optimum care, with people having the freestyle Libre, having education, and having the best available insulin options, the differences between basal insulin and intensive insulin was very clear. Clear in the number of hypos, clear in the duration of hypos. All this was very clear in numerically. Statistically, it did not make difference because possibly the numbers were pretty small, but for any individual, they would be concerned to increase their duration or the frequency of hypoglycemia. So for any individual who is on insulin before Ramadan, we need to do the risk quantification, advise them on the timing and the frequency of monitoring, advise them on the food, activity, physical exercise. Of course, we need to choose the medication and adjust the dose accordingly, give them solid advice on when to break the fast, and reinforce the recognition of the symptoms of hypo or hyperglycemia so that they can sail through Ramadan and beyond safely. We recommend that people should be consulted well before Ramadan, and if they're on insulin, such as basal insulin, they switch the injection, if it's once daily, to iftar time and reduce the dose by 15 to 30%. If they're on twice daily, then they take the larger dose at iftar time and reduce the suhoor dose, the early morning dose, by 50%. We provide them with an algorithm where they can review the results and adjust the dose based on Ramadan targets. And Ramadan targets are a touch higher than other targets. So the target during Ramadan is 90 to 126. And if they are lower than this, to reduce by 2 units. If they are seriously lower than this, then they can even reduce by more. And of course, if they are higher, they should increase the dose, because we do not want hyperglycemia during Ramadan either, or in any days of the year, of course. So I would like to review with you one very important trial that we've done on insulin glargine 300, the Orion study, where it was real-world safety data for the effectiveness and the safety of insulin glargine 300. Here, we looked into people who were already on glargine 300 a minimum of 8 weeks before the study started, and they had the intention of fasting the month of Ramadan. We looked into the pre-Ramadan duration, which was a maximum of 3 months, the month of Ramadan itself, and then another month post-Ramadan. This data is already published in DRCP 2 years ago. As I mentioned, we advise people to adjust the dose based on the guidelines or their own discretion. So clinicians had the opportunity to adjust based on what they felt is appropriate. We just highlighted to them the guidelines. And the primary objective in the study was to look into episodes of hypoglycemia. And this was defined as one or more episodes of severe and or symptomatic documented hypoglycemia with self-monitoring of the blood glucose of below 70 milligrams per DL or 3.9 millimole per liter during the pre-Ramadan, Ramadan, and post-Ramadan period. So it's not just about Ramadan, but obviously throughout the length of the study. We had approximately 500 persons from many regions in Middle East, Turkey, Gulf region, Indian subcontinent, and Malaysia. We looked also into having a proportion of the study. We had 25 persons from Canada, and it's quite interesting to have this group of patients with us in the study. The average age was in the mid-50s, nicely split between men and women, and as you expect with type 2 diabetes, the vast majority are overweight, close to obesity, with a BMI of 29.7. Duration of diabetes in the majority, over 50%, 53% were less than 10 years, and for the rest, it was over 10 years. By applying risk calculation of the guidelines that were available at the time of the study, the vast majority, 82%, were in the moderate to low, and the rest were either high or very high. Very important to remember that 47% were in sufferniria. You would recall earlier in my presentation, I've shown you when you have insulin and sulfonylurea together, the rates of hypoglycemia are much higher when compared to those who are on neither of them. So what happened during the month of Ramadan? Well, the pre-Ramadan dose was of insulin was 0.32 unit per kilogram. And quite interestingly, that the change was very minimal because it was 0.3 and went back to post-Ramadan dose. So the clinician, for whatever reason, did not feel that they needed to reduce the dose with the same percentage that we've mentioned. In fact, 94% of the persons during Ramadan with the glycogen 300 had no interruption of treatment during the month of Ramadan. Now, the fasting, here is a person on insulin, and 47% of them are sulfonylurea. So you're concerned on whether they will be able to fast the month or not. And I'm delighted to see that 85% fasted the full month, and another 10%, 10.8% fasted 25 days or more. So very clearly that the vast majority of the patients were able to fulfill their passion and nearly fast the full month apart from few days. Those who fasted less than 15 days are indeed less than 1.2% added together. Hypoglycemia. We mentioned that we wanted to measure severe and or symptomatic documented hypos, defined as below 70, or equal or below 70 or 3.9, depends on the measure, milligram or millimole. Before Ramadan, it was 2.2%. During Ramadan fasting for roughly 15 hours, this only changed from 2.2 to 2.6%. And when you go to the more symptomatic, the more severe, below 54, this was 0% during Ramadan and was 0.8% pre-Ramadan. So it's quite interesting that the severe type of hypoglycemia did not happen before Ramadan, and it happened, during Ramadan, but it happened pre-Ramadan. Post-Ramadan, there was no hypos in the severe rate, and in the minor rate of below 70 or below was in 0.2%. And this is obviously very reassuring, and it is very different from what we saw in other studies on patients on insulin. So when we look into the regions, and this is here the point of geographical distribution. Now, the 13 participants who had hypoglycemia in the study, 6 of them, nearly 50% of them, were among the 25 persons living in Canada, while the other 400 plus, the study was nearly 500 persons, so here is 465 or 75 nearly, had 7 episodes of hypoglycemia. So what's the difference? I guess perhaps it's related to the duration of fasting in Canada, perhaps related to the physical activity, perhaps related to the glycemic control. I'm not sure, but the geographical differences here is very obvious for all of us. Now, hypoglycemia was pretty rare and only increased from 2.2 to 2.6. What about glycemic control? Well, it improved. The HbA1c dropped by 0.4% from pre-Ramadan of 8.1 to post-Ramadan of 7.6. And similarly, the fasting plasma glucose dropped from 144 to 128, and the SMPG fasting reduced from 130 to 126.8. So all parameters of glycemic control improved, even though we did not have an increase in insulin dose to match the baseline of 8.1, where you would expect that perhaps clinicians would have pushed the dose higher to fight the hyperglycemia. I guess they opted for a cautious approach, knowing that Ramadan is coming. But clearly, My reflection on this, with the very low rates of hypoglycemia, I would take stock from this and say, I would be able to escalate the dose to get better control, knowing that the rates of hypoglycemia were pretty rare. It's very important to supplement the advice of the therapy with the advice on many other things, including the food intake in Ramadan, avoiding excessive calories, avoiding the excessive carbs and sugary, and eating quickly and having rich snacks as well. Avoiding eating suhoor early. We need to delay the suhoor as much as possible, which is also part of the teaching of the Prophet Muhammad, the Sunnah. And certainly try to select the right type of food, avoiding the large quantities of high glycemic index, type of carbs and fried food, and try to sleep appropriate number of hours in Ramadan. Much of this information is in the application that we provide for people with diabetes, which we call Dar Safa, and Safa is the abbreviation of safe fasting. And that is available for everyone to download the application or through the website. And this was supported by an unrestricted grant from Sanofi. In the app, they will find plenty of information of the type of diet. Here is the information in Arabic, but indeed it's available in English, Urdu, and French, and hopefully more languages to come in the future. Now, I would like to move to another important data with basal insulin glargine in combination with lixisenatide in a fixed ratio pen, the study which we called the SOLIRAM trial. And I'm delighted that we got the acceptance for the publication just a few days ago on the 11th of January, as you can see from this cut from the website. The study, as I mentioned, is a real-world trial from multiple countries, multiple centers, and it was conducted over 2 consecutive years to get all the population that we wanted for the study. We wanted people to be on the study who had the intention to fast and who were already on the combination of insulin glargine with lixisenatide in a fixed ratio combination. Similar to the Orion study, up to 3 months pre-Ramadan, 1 month of Ramadan, 1 month post-Ramadan. The primary objective, again, identical, of looking into hypoglycemia with the same targets of documented and or severe symptomatic hypos of less than 70 milligrams per DL or 3.9 millimole per liter before Ramadan, during Ramadan, and after Ramadan. The patients, obviously, or the people with diabetes, were on large number of different types of therapy. Big ones of 54, metformin, sulfonylurea, again, nearly 44%. So here you can see that the type of person with the combination of basal insulin glargine and sulfonylurea, which we said was seen in the past to show high rates of hypos. And of course, with the presence of SGLT2 inhibitors, 40% of the persons in the study were on SGLT2 inhibitors. Most participants in the study took the injection in the evening at iftar time with a mean dose of nearly 25 units, 24.9 to be precise. Only 11% took it in the morning. The ability to fast was fasted the whole month, because it varied from one country to based on the 2 years, whether Ramadan was 29 or 30 days, but 93% fasted the whole month. Another 3.7% fasted between 25 to 29 days. And those who fasted less than 15 days were the minority of 2.4 and less than 0.7%. So, as you can see, the vast majority, 97% nearly of the population fasted 25 days or more. Now let's look into hypoglycemia. So again, I remind you, this population is everyone on a fixed ratio combination of insulin glargine along with lixisenatide. 43% are also on sulfonylurea. Rates of hypoglycemia before Ramadan were 1%. Rates of hypoglycemia during Ramadan was 2.3%. Post-Ramadan was 0.3%. The hypos occurred in 1.8% in the fasting hours and 0.5% in the non-fasting hours. If you look into the more severe hypoglycemia of less than 54 milligrams per DL or less than 3 millimoles per liter, this was pretty low, 0.2% in pre-Ramadan, 0.5% during the month of Ramadan. So out of the study, those who had hypoglycemia was very small numbers indeed, considering the type of therapy that people were on. And the beauty is that glycemic control also improved during the month from a baseline of 8.2 to 7.5%, and fasting plasma glucose improved from nearly 140 milligrams per DL to 121. And weight also improved from 85.9, nearly 86 kilograms to a mean of 84.5 kilograms during the month of Ramadan. So kind of observation of improvement in glycemic parameters, improvement in weight, rates of hypoglycemia were bare minimal. So all this gives us huge confidence that the fixed ratio combination of second generation basal insulin glargine 100 along with lixisenatide had very low rates of hypoglycemia while sustaining good glycemic control and able to improve on their weight during the month. So ladies and gentlemen, the key takeaways messages. With the correct guidance, many people with diabetes can fast during Ramadan safely, but they must, of course, undergo close supervision by experienced, well-trained healthcare professionals on the risks of fasting and the best management of Ramadan fasting. When we look into the studies, we can see that second-generation basal insulin, as well as basal insulin, whether it's glargine 300 or glargine 100, mixed with the lixisenatide and fixed ratio combination, help people to fast Ramadan with sustaining good glycemic control and even improvement and weight reduction in the lixisenatide arm, and with low incidence of hypoglycemia with a marginal increase during Ramadan compared to before Ramadan. This gives me the confidence that what we are talking about today, basal insulin glargine 300, as well as the fixed ratio combination of insulin glargine with lixisenatide, can represent an effective and safe treatment option for people with type 2 diabetes during and indeed out of Ramadan months as well. I'd like to stop here. Thank you all, and I look forward for any questions.